Thank you to ABB and X-Cel for hosting us tonight. Hopefully we can provide some quality education. We'll be talking about the REMLens, which is the new orthokeratology design from X-Cel Specialty Contacts. And I like talking about this lens because it's fun. It's kind of a classic X-Cel product in the sense that they offer it with a very straightforward, simple, easy to use fitting process. But at the same time, they've made it extremely customizable. So if you're new to Ortho-K and you want kind of a plug and chug system, you enter your Ks, you enter your RX, and you get a lens that works the majority of the time, it can work for you. If you're somebody who likes to manipulate things and really become a perfectionist with your results, then it's probably the most manipulatable lens on the market at the moment. So that's fun. We'll talk a lot about it. It is under the Boston Orthokeratology, or BST, platform. That platform was approved back in 2004 by the FDA for overnight use a few years after CRT was. I think that's important, and I always remind patients of this. I'm sure if you're doing Ortho-K now, or if you even just brought it up to patients of yours, you know that it's not the most well-known treatment system out there, and it's a strange word, and parents typically give you a strange look when you bring it up, and it does require a decent amount of chair time and education because it is something that's foreign to a vast majority of the population out there. That will probably change over the next few years here as myopia control continues to become more mainstream, but at the moment it's still something most people haven't heard of. And when they haven't heard of it, obviously they're going to be somewhat apprehensive, and reminding parents or patients that this treatment has been around since the 70s, but it was FDA approved about 2 decades ago and has been used safely ever since, often helps to put them at ease. I always tell parents the one risk that we have with Ortho-K after 20 years of FDA approved data is the same risk as we have sleeping in any type of contact lens. And for that reason, practicing good hygiene and having the parents involved when young children are wearing these lenses in the hygiene is extremely important in preventing microbial keratitis, which is kind of the worst outcome with Ortho-K. So as far as on-label indications go for the VST system, we can treat up to 5 diopters of myopia, up to a diopter and a half of cylinder. It's much more effective with the rule cylinder, a wide variety of base curves, and as we'll talk about in detail, that the REMLens utilizes a wide variety of diameter and optic zone options. It's currently available in the Boston EquiLens 2 material. That's approved for daily wear, extended wear, and overnight Ortho-K. There's a few different systems people utilize. With Ortho-K lenses, often the parameters of the eyes are very, very similar and can be difficult to distinguish with lensometry or a radioscope. So using different colors for these buttons can be extremely beneficial. A lot of people use red for the right and yellow for the left for obvious reasons. There was a shortage at one time with red buttons, and so we switched over to blue and green, where the second letter of the color indicates the eye that the child should put the lens in. So if they ever do get mixed up at home, or if they come into the office and are unsure, it's easy for the parents or the staff to differentiate the right and left lens. Just kind of a quick recap, how does orthokeratology work? We're going to be flattening the central cornea and effectively steepening the mid-peripheral cornea to create an oblate shape similar to that we find with LASIK and other forms of laser refractive surgery. Mainly what we're doing here is manipulating epithelium through a couple different mechanisms. One, we're probably displacing some epithelial cells from central cornea out to the peripheral cornea. We're also just kind of squeezing the contents of those epithelial cells, the organelles, the cytoplasm, through those gap junctions laterally out to the mid-periphery, where they'll bulk up and again create that nice flattened surface for us. If you kind of think about the thickness of the epithelium and what we're trying to achieve with orthokeratology, it really explains why Ortho-K for patients minus 350 and less is relatively easy, and it gets a little bit more cumbersome, a little bit less predictable as we get into the higher myopes. And if you use kind of that standard LASIK equation that helps you calculate ablation depth for myopia treatment, we look at we need to flatten about 12 microns for every diopter of myopia, assuming about a 6 millimeter treatment zone. So knowing that the epithelium is 50 microns thick, really about 4 diopters or 48 microns that would equate to is as much as you can do to flatten out an epithelium, and really it's probably less than that. We are probably moving some stroma even in the mild cases, but the epithelium is mainly what we're redistributing. So when you get over that minus 350 and minus 4, I have conversations with patients and parents about, hey, we can do this. We will probably have some good results. There's a chance it might not be as stable. There's a chance we may have to tweak the lens a few times to get it where it needs to go. And we have less guarantee as far as what the visual outcome is going to be. That being said, one of my case reports will show somebody significantly higher than minus 350, in fact, about twice that, who corrected very effectively with the REMLens design. So again, we're flattening central cornea, steepening mid-peripheral cornea to correct myopia. I was just for legal reasons and liability reasons make a point to point out to parents that orthokeratology is FDA approved for the treatment of myopia. It does not have the FDA approval for myopia control or the slowing of axial length growth. Obviously, we know through a ton of research, a ton of data from all over the world, that Ortho-K is a very effective myopia control device. But as far as FDA approval goes, what it's approved for is a correction of myopia. Doesn't change the safety or efficacy if you're using it in a more myopia control setting. But I do think that's important just to have that out there, and that is in our disclosure agreements that we have patients sign as well. There's a lot of press and a lot of advertising around, how orthokeratology can protect people's eyes in the future, and there is some validity to that. We know as people become more myopic, especially in that higher -6 and over category, the risk of things like retinal detachments increase precipitously. We know there's higher degrees of glaucoma, cataracts can form earlier, and really progressive myopia, we can have myopic macular degeneration, things of that nature. And I do always mention that to parents. And if there is a very high risk child, this is something I might lead with. Like today I saw, he's actually in a custom soft lens. He's a -9 prescription, and he just turned 9 years old. And that's somebody we're going to be aggressive with a variety of different methods for myopia control from an ocular health standpoint. But the majority of patients who are fitting in Ortho-K, mild to moderate myopes who are young, mainly what we're trying to do is just improve quality of life when they get older, and not necessarily do this just for the decreased risk of these ocular diseases, because let's face it, all those diseases are still going to be relatively uncommon, regardless of the degree of myopia. And I think what I found just anecdotally when you talk to parents, if a parent's myopic, which they most likely are if the child's myopic, and you start throwing around these things like retinal detachments and glaucoma, if we let them get too nearsighted, well, that parent who's been nearsighted since they were 14 years old tends to say, well, I got by just fine. And, I know a lot of people who are nearsighted whose retinas aren't falling off. So I don't think that's as powerful as a motivator. I do think, like I said, really kind of driving home, if we can keep Danny here at a -1, he's at a -75 now, or -125, we can keep him around that range. He can be functional uncorrected. He will require less as far as high index lenses and be less dependent on glasses and contacts, which I think resonates well for parents who are very dependent on contacts and glasses. And then one thing that hits home for quite a few parents is, hey, we can keep him in this category where he'll be a really ideal LASIK candidate, because let's face it, the more myopic you are, the more ablation you have to do, the higher the risk of nighttime glare, aberration, dryness, and other side effects associated with LASIK. So preserving their vision can have huge consequences down the road as refractive surgery candidates, and then just as far as everyday life and having to deal with vision correction or the lack thereof. And that tends to resonate well with patients. I always tell them what's fun is the next 5-6 years when we're going to have them seen well without contacts or glasses. But where this really pays off is from age 21 to 80, when they get the benefit of not being more myopic and more heavily dependent on those devices and vision correction options. So one thing that we can manipulate pretty liberally with the REMLens is the optic zone. And I have a lot of fun with this, because depending on who we're treating, being able to manipulate that optic zone can enhance things like myopia control, and can also, on the flip side, degrade things like vision in somebody who's not looking for myopia control. So the REMLens has 6 options as far as the optic zone goes. The standard will be a 6 millimeter optic zone, and it goes up or down in 0.2 millimeter steps, down to 5.4 and up to 6.4. And this can be utilized in a lot of different ways. For children, I tend to trend a little bit smaller. I'll show you the next slide. You like that peripheral defocus ring to be, really about the 5 millimeter or in kind of cord length in order to maximize myopia control. And there's some pretty decent studies out there that show a much better axial length control in patients who had 5 millimeter or smaller peripheral defocus rings versus larger. So I like to err on the side of a little bit smaller. Children tend to be less bothered by the glare and aberration that comes with that. As long as they can see 20/20, they tend to be happy. That's one reason Ortho-K is really a lot of fun, is because the kids just don't complain nearly as much as the adults do about the little things. If they can see and mom's happy, they're happy. On the flip side, if you're treating somebody in their 20s or 30s, night vision, glare, aberration, these things become more important, and moving into the larger optic zones can help minimize those unwanted side effects. A lot of this will be pupil dependent. There's no one size fits all. You have somebody with a very myotic pupil, you can stay with a standard 6 millimeter optic zone. Somebody with a very large pupil and blue eyes, we may go up to a 6.2 or 6.4. This can also come in handy for your early presbyopic patients. That peripheral defocus ring acts kind of like a center distance multifocal. And that makes sense because we use center distance multifocal contacts for myopia control as well. So what I'll do a lot of times is I'll put a little bit larger optic zone on the dominant eye, a smaller optic zone on the non-dominant eye, and try to get some near vision improvements in those early presbyopic patients. There's a limitation on how much near vision you're going to get out of this. You can also move to a modified monovision and undercorrect an eye if they desire more independence from over-the-counter readers or any kind of prescription glasses. So this is what I was talking about here. This is that peripheral defocus ring. This black circle here, if you can see my cursor, is the 5 millimeter cord length. So we're pretty much straddling that peripheral defocusing. That's pretty ideal for me. A little bit smaller would even be fine. Again, if you go too small, you're going to degrade vision, and the patients are going to know that, and the parents are going to see, because they always see how far down on the chart their child can read that day. But this is a pretty ideal diameter for peripheral defocus ring on a myopia control patient. Another thing very customizable on the REMLens is the diameter option. There's 5 diameter options on the REMLens, and that's important because it allows you to have a wide range of diameter options, but also allows you to make small steps, because making large steps in diameter can sometimes throw off other parts of the fit. We're dealing with different portions of the cornea, and depending on things like eccentricity, when you really start increasing or decreasing diameter, dynamics of the fit can change, even though these do have independent zone manipulation abilities with all of the zones within this lens. If you affect diameter too much, sometimes that can become unpredictable. So the average cornea out there, 11.3 to 12.3 with HVID, 10.6 lens is going to be indicated. The diameter options range from 10.0 to 11.2, and they recommend the largest lens, 11.2, if it's a 12.4 or larger cornea. And then if it's under 11.2 millimeter cornea, then go with a 10.0 lens. This is very important, because if you have somebody with a small cornea and you put an average lens on them, it's just not going to seat right. If it doesn't seat right, it's not going to applanate right, and we're not going to get proper treatment. So taking good visible iris diameter measurements, usually this is done with your topographer, is very, very important in making sure we get first fit success with the REMLens. So as far as evaluating the patient initially, there's not a whole lot of surprises here. Obviously, we want to do a very accurate refraction. If you're not sure and the refraction is kind of mushy, cycle them. Some people like to cycle all of their patients before orthokeratology. I like to think I've gotten to the point where I can kind of pick out a pseudomyope just through the accuracy of their manifest refraction. But if I'm ever unsure at all, or if it's been a big change or something more than I'd expect, we'll cycle them in the office that day. But an accurate refraction, obviously slit lamp evaluation to make sure there's nothing that contraindicates the patient. And then you want to do obviously keratometry. I highly recommend utilizing the keratometry readings from your Ortho-K as opposed to Placido disc topographer that's more tear film dependent. Any Placido disc topographer you'll find is going to show you very different readings with a good tear film versus a bad tear film. And for some patients, that can vary blink to blink. Kids tend to have good tear films, but there's still some unpredictability there. And I think it's more accurate to use an autorefractor. If you have a Pennicam, that's what we use, and you're using Scheimpflug imaging, that tends to be very accurate because it is tear film independent. One way you can kind of check your work, if you do Auto-Ks, have your technician do a topography after that and make sure your Auto-Ks pretty much match your topography. If they don't, redo the topography with an artificial tear in there and try to get more accurate results until those two numbers correlate. But Auto-Ks tend to be more reliable than topographic Ks, especially again with placidodisc topographers. You still do need corneal topography. You need to be able to analyze if there's astigmatism on the cornea that's maybe not showing up in the refraction, because while that doesn't affect the optic of the lens, it can affect the stabilization zone, or how we fit the lens so it stabilizes on the eye. You just want to rule out pathology like risk of keratoconus, which would be a contraindication for orthokeratology wear. Corneal eccentricity values and obviously visible iris diameter are also very helpful in determining lens parameters and can really benefit first fit success rates. So with the REMLens, just like with all other Ortho-K designs, we have 4 zones: the treatment zone in the center that'll applanate and flatten the central cornea, the reservoir zone in the mid-periphery, then the stabilization zone. That's actually the first zone to contact the cornea. There's a very, very thin tear layer underneath that treatment zone, too small to be picked up with a slit lamp, 10 to 15 microns thick. So the stabilization zone is actually where the contact rests on the eye, and therefore that's what we utilize for alignment. And then unique to the REMLens is the dynamic profile, dynamic edge profile zone, which we'll talk about in a second. The treatment zone is pretty cut and dry. It's pretty standard. We're going to order a base curve that's flatter than the patient's flat K to equal the amount of spherical myopia that patient has. So if they're -3, we're going to go 3 diopters flatter than flat K, and then an extra 0.75 diopters flatter to allow for regression, that Jessen factor that allows the patient to pop out a little bit over the first day or two without losing distance visual acuity. Next, we have the reservoir zone. This is kind of the secret weapon of orthokeratology designs. This is the reverse curve that allows us to bridge that central compression treatment zone to the stabilization zone. It also has a good amount of room in there for that central tissue that we're going to push toward the mid-periphery. So it allows some of that epithelial tissue to accumulate. And then also having that fluid within that zone creates that kind of hydrodynamic force that helps to draw the cornea out and flatten it out into the oblate shape that we expect to see. It's an independently manipulated zone. I'll talk more about that in a second. And it should be noted, and this will show up in a case report as well, we can raise and lower the height of that reservoir zone in order to also manipulate the treatment of central cornea. Obviously, lowering that zone will give us more pressure centrally and allow for more treatment of myopia. And that can be used in certain situations to our advantage. Like we talked about a second ago, the stabilization zone is the part of the lens that really kind of rides the eye. So this is going to be fit based on keratometry values. It's going to be fit slightly flatter than K to allow for corneal eccentricity. Again, if you give the consultant eccentricity, and that eccentricity is greater or less than average, this zone can be manipulated accordingly. This is where also the toricity really comes into play. Toricity will start in the reservoir zone, but can flow out into the stabilization zone. And so if we see toricity on topography, we can include that in the back surface of this lens to allow for better stabilization. And we're finding that we're doing that more and more, even if we're not picking up a lot of refractive cylinder, because the toricity is not necessarily something we're looking to correct from an optical standpoint. It's all about centering the lens. Centration of the orthokeratology lens is paramount to good, crisp vision. And if we need to account for some toricity to do that, then that's something that we should implement right from the get-go. Finally, we have the dynamic edge profile zone, very unique to the REMLens. This is a very customizable zone. It can move a pretty large amount, and it can be utilized in a few different ways. It's going to be flatter than the stabilization zone. We do expect edge lift on the edge of any orthokeratology design. We need edge lift so that that stabilization zone can seal and create that kind of hydrodynamic effect that we need within the reservoir zone. So we need some edge lift. Insufficient edge lift will affect the fit for the reasons we just talked about, and also possibly create adherence in the morning. So being able to lift that edge can alleviate that. And then too much edge lift can lead to a lot of awareness. And one of the biggest challenges we face initially is comfort with these lenses. And in young children, some seem to be more sensitive to that than others. But if we are having somebody who's extremely sensitive, one thing we can do is tuck that edge down without giving up some edge lift in order to improve on-eye comfort. So just an example here on both the 10.6 and 11.2 diameter lenses, how that can be flattened or steepened. So flat will lift that edge and steep will tuck that edge down or steepen it. To order the REMLens, it's very, very simple. There's an online calculator. You can put in very little information and get a lens spit out. You can put in more information and you tend to get better information out. So steep and flat K with the axis, obviously the refraction and the HVID. It's going to give you a lens diameter. It allows you to put in eccentricity values and pupil diameters as well, which can be very helpful. And a lot of times if you put those in, it might not change a lot about the initial lens selection, but having that information in the system, when you go back and say, why is it doing this or that, those a lot of times can answer questions for you. And that answer becomes much quicker to arrive to. So if we zoom in down at the bottom here, everything is given with the exception of the base curve in sagittal height. So our reservoir zone, stabilization zone, edge zone, total lens sag, everything's given as a function of height. So in this case, the reservoir zone is 310 microns tall, or 0.31 millimeters. That can be manipulated along with the stabilization zone and edge zone. All of those can be raised and lowered in 10 micron steps. So very, very customizable. You'll also see this lens code that's provided. That lens code will be engraved onto the REMLens itself. It's going to give you all the information you need to reorder that lens. It's going to give you the base curve or treatment zone, the height of the reservoir zone, stabilization zone, and edge, and then it'll tell you if there's a toric factor built into that lens as well. So very, very helpful. As far as information that we need to write down and give to the consultant when we order these lenses or when we troubleshoot these lenses, number one thing is when we go to dispense the lens, obviously we've already at the initial appointment taken a manifest refraction, all the other measurements we talked about earlier. When we go to dispense the lens, we need to notate how that lens rests on the eye. So utilizing fluorescein and a Ratten filter, we want to see if that lens is decentering superior, inferior, nasal, or temporal, or if there's not enough applanation centrally like we see in that bottom picture there. If it's not sitting perfectly, don't be discouraged. A lot of times we'll see inferior decentration on these lenses at dispense, but on a closed eye situation, in a closed eye environment, that lens centers up beautifully. So while it's important to notate where this sits, because that can be helpful for consultation later, what we really care about, and what's really going to tell us what's happening when the eyes are closed and when that patient is sleeping, is the topography data. We can have a perfect bullseye topography with an inferiorly discentered lens on slit lamp, and I'm still going to keep that lens all day because I don't care how that lens sits on an open eye. I care how it sits on a closed eye, and that's what the topography is going to tell us. It won't tell us that at dispense. That's going to be at the 1-day follow-up or the 1-week follow-up, but at least it's going to give us an idea if we're centering that properly. So not only should we write down how is that lens centering, initially we should also make sure to notate the topography image. That'll also be very helpful for the consultant. Also at the dispensing visit, you should also do a refraction and over refraction over the top of the lens. And then obviously you'll do manifest refractions at the follow-up visits to see what the residual prescription is, targeting a +50 to +75 in the morning, closer to Plano in the evening. So again, very customizable lens, wide range of parameter options. If you're somebody who just wants to put numbers in and get a lens, 85% first fit success rate, you can definitely do that. If you're like me and you like to make small manipulations to try to get things better, you can definitely do that as well. Again, 10 micron steps up or down with a very wide range in all the reservoir, stabilization, and edge zone. And then for toricity, there's 3 steps of toricity. The first step is 30 microns of toricity, and they go up in 10 micron steps from there. You can either kind of ballpark it and say there's a mild amount of toricity, less than a diopter, let's start with 30 microns, or you can do an elevation map and actually measure the difference in elevation between your steep and flat meridians, and use that to better estimate how much toricity to start with on the REMLens. So a couple quick case studies before I turn it back over to Tony here. This one was interesting for a couple reasons, and it's actually still kind of a work in progress, but I thought I'd share it. It was a 10-year-old who came in. He was blurry in his right eye. It was affecting his ability to hit the ball during baseball, right? It was affecting his hand-eye coordination, his depth perception. As you can see, 20/80 in the right eye, 20/20 in the left eye, a buck and a half with some residual sil in the refraction. My tech still often flip flat and steep topography data or characterometry data here, but you can see about a half a diopter of toricity on the cornea there, which matches up pretty darn well with refractive sil. So a pretty ideal candidate for Ortho-K, but at the same time, you know, could be a candidate just for spectacles, soft contact lenses, etc. Given that he's 10 years old, and I soon found out his mother wears -9 diopter contact lens, I said, hey, let's be a little more aggressive with this just in case. We probably would have seen some more myopia by your age if you were on that course, but better safe than sorry. Let's use some myopia control. Playing on a dirty baseball diamond, I said, well, let's utilize Ortho-K because we won't have contact lenses getting gumped up with dirt and debris and everything else that comes with baseball. And if it dries out, all of a sudden you can't see out of it. So Ortho-K became kind of the go-to option for this patient. The one thing I will say that I've been very careful with this patient with, even though he's 10, he's, depending on who you ask, pretty much past that critical period. I was very careful. I didn't want to over plus him in order to create a potentially amblyogenic situation. That's very low risk for a 10-year-old who's been myopic in that eye. But again, something that you should keep in mind, especially in a younger patient who has asymmetry. You don't ever want to over plus one eye with an end treatment result, because again, we don't want to suppress that eye. So we ordered the lens through the calculator, we dispensed it, everything was going great at the 1-day follow-up. It came in at the 10-day follow-up, and he had a really great topographical pattern. It looked really good, almost no SIMK sil, really pretty ring of peripheral defocus. It was a little blurry, and I assumed he would be slightly under-corrected when I walked into the room. But to my surprise, I got a +175 refraction over that patient. So he was significantly overcorrected. So I reordered that lens. And I will say, whenever I saw this initially, we did cycle him the first day. So this was this was a real amount of myopia there. So we ordered that lens with a steeper base curve. That steeper base curve would reduce the amount of treatment we got centrally. And then we saw him back another week and a half later. We switched topographers at that time, but same patient. What we found was he was 20/20, but he was complaining more of aberration type symptoms. And the treatment zone wasn't quite as pretty. It had shrunken in a little bit, had some more asymmetry to it, and it just wasn't quite as oblate as we wanted it to be. The numbers matched up. So we had that +50 over refraction, he was 20/20, but I wasn't super happy with that. So what we've done subsequently, and we're still waiting to see him back for this, but what's nice about the REMLens, since we had such a nice treatment pattern with the flatter base curve, we went back to that flat base curve. But in order to reduce the amount of effective treatment, we increased or raised the sagittal height of that reservoir zone. And every 10 microns you go up, you get about 0.5 to 0.75 diopters of change in myopic correction. So by raising it, we should lower his myopic correction by about a diopter. So I'm anxious to see him back, but what it's going to allow us to do, instead of steepening the base curve and therefore taking away some of that plateau effects, taking away some of that central oblate pattern that we're looking for, we can maintain that and utilize the reservoir zone to increase the overall sagittal height of the lens and therefore reduce the amount of effective treatment. This is another one I put in here just to show you that these lenses can be capable. We talked earlier about the 350 and under being more or less slam dunks, and really 3 and under is kind of slam dunk. Anything over that gets a little bit more hairy, but it doesn't mean you can't do it. I just think you have to be more careful about setting expectations for those patients. And this is a perfect example. This was a 24-year-old female. She came in and she was dead set on Ortho-K. Her friend has done it. She had family members who had done it. She did not want to do LASIK because she was still changing. She was concerned about some of the dryness associated with LASIK because she had contact lens dehydration in her soft lenses. We did a refraction, as you can see at the bottom. She was pretty darn myopic, especially in her right eye. So I pretty much told her you're not a good candidate for it for a few reasons. One, she had way more keratometric cyl than she had refractive cyl. She was obviously above what we would indicate a lens be fit in that right eye, but she insisted on going through with it. And this is, I think this is, yeah, the 10-day follow-up. Again, just first lens, put it into the calculator, spit out our parameters, extremely flat. You can see in that right eye, a 978 base curve to flatten out that minus 675. A little bit of inferior decentration, and obviously a little bit smaller treatment zone in the right eye that we had to applanate more, which what we would expect. But I'm hesitant to touch that because we kind of nailed it on the first try. So I left it alone. She was happy. She did notate a little bit of nighttime glare. I had warned her about that. She could not be more thrilled, but it just goes to show you never really know how a patient's cornea is going to react to Ortho-K, especially when you get into those higher myopic ranges. But setting proper expectations and the possibility that 20/20 vision might not be attainable through Ortho-K alone is something that you should definitely review with patients. And we have them sign a piece of paper saying that, you know, in our disclosure form saying that, hey, we don't guarantee 20/20 vision with this. And in some patients who come in and they're motivated for their children to be in Ortho-K, usually they end up being 20/20, but I tell them there might be a small chance we have to use some glasses to clean up some prescription for your son or daughter. The beauty of that, though, is that they still get the myopia control effect. They still get that peripheral defocus ring. And if we have to put a half diopter of minus and a little bit of cyl and a pair of glasses to go over the top of it, they're still getting all the benefits of Ortho-K. They still are going to be mainly glasses and contact free, but can utilize glasses as needed to crispen up the vision. So it's not necessarily a contraindication. It just needs to be made very clear to the parents and or the patients that that is a very real possibility, especially as we get higher up in degrees of myopia.